today's lecture, what we're going to be doing is we're going to be doing prioritization. But prioritization is getting harder and harder when we're talking about the boards now. The boards are constantly evolving, they're constantly changing. And now prioritization is actually getting harder. It wasn't as easy as it used to be. So these questions that I've created are fairly tough. And I want you to kind of see the mentality of exactly how we're approaching what AskGraph is, why we use AskGraph, why I don't think ABCs or any other, not that I'm knocking any of the other ways of doing prioritization, to each their own, but for my students that understand AskGraph, that like AskGraph, there definitely is a benefit to having that advantage going into this exam, because again, the biggest thing you can do is give yourself an advantage walking into this exam. So again, with AskGraph, I'm going to give a brief overview. Of course, it goes way more in depth, but I want to do application. I want to try to see if everyone can work through the method, which again is going to help you throughout this process of answering the question. And then we'll go through AskGraph, so on and so forth. So now let's get some announcements out of the way, and then we'll go ahead and get started on our lecture today. So a couple of announcements. One is financial assistance letter is available. Again, I understand that times are tough. Everything is expensive right now, which is why I've got some announcements regarding the upcoming courses. Financial assistance letter is there. Ask community, religious organizations, family members, whatever it takes to get through this exam. Trust me, it'll be worth it in the end. You're not going to regret it the least bit the minute you get licensed. Tutoring is $65 an hour. Every one of the tutors has been in your position. They're all, most of them are repeat test takers, and they've all gone through the program. They've all gone through training with me. They all report to me. So if you're working with a tutor for $65 an hour, at least know where you're getting your tutor from. I know a lot of people like to get tutors, but you don't want to go to a tutor and be like, oh, let's practice AskGraph, or, I learned about NIPA and needs, and they don't know what you're talking about. At least when you're working with our tutors, they know exactly what you're talking about. Being an NCLEX High Yielder, being part of this community, that you have certain things that you've learned a certain way that are going to help you get to the end result that we're looking for. Take advantage of free resources. Look, we dropped a couple of YouTube videos. We dropped a couple of podcasts. If you're not signed into all our free resources, scan that code right now. Subscribe to our YouTube, subscribe to our podcast. We're putting new stuff out all the time. So make sure that you've got access to all that. Instagram, TikTok, Facebook, VIP group. Make sure you're following us. There's nothing better than some free stuff just like you're getting today. Our self-paced course is now at a discounted rate. So it's even cheaper than it was. I think it's like $200 and something. Like, it's cheap right now. So go grab it. There's only 2 courses left for the remainder of the year. There's only 2 courses left for the remainder of the year. So make sure that you are signing up and or taking advantage of these dropped prices right now. There are cheap prices for everything. Self-paced course has been dropped. It's like 200 something bucks. The live course in October is only $319 because they're limiting spots. What we've learned from this last course is that we like smaller courses. So get in while you can. We're only letting a certain amount of people in. That's why we dropped the prices. First come, first serve. First come, first serve. So again, get in while you can. There's only 2 live courses left. The one that we've got coming up right now is in fact starting September 30th. So less than 2 weeks. If you're trying to get into a live course, get in now. Again, look, if you are doing anything illegal, if you know anybody doing anything illegal by pirating or buying stuff that's off the market, they're tracking every single email. That if you've gotten it or you see somebody posting it, I would highly recommend reporting it right away, getting on the good side of this situation, because there's nothing good to come of this. They're making you publicly acknowledge. They're reporting it to all 50 states plus Canada at the board level. The lawyers they're finding if you've paid via Zelle, Cash App, um, PayPal, Venmo, they're tracking it all the way back to the person that, and they're subpoenaing, I think that's the word, subpoenaing all the records. So if you were involved or you know anybody that was involved, I would be proactive and just say, hey, I'm sorry I did this. They're probably going to be forgiving. So just, there's an email. You should get legal representation if you don't have it. So, and if you find it, report it. You can report it to contact@nclexhighyield.com. You can even report it, contact@nclexhighyield.com, and just say, look, I found this on Etsy. I found this on Facebook. Not that you were a part of it, but if you find it, we appreciate it. If you were a part of it, come forward. They're not going to get you in trouble if you come forward, but if they have to come after you and subpoena stuff, then you're looking at losing your entire license. So just don't do it. It's just not worth it. I don't understand why people don't realize that. It's just not worth saving a couple of $100 to jeopardize your entire life. It's just not. It really isn't. So again, I hate to talk about that stuff. It's not my job to do that, but because I have a platform, it's put on me. This week's group study is completely sold out. I believe so, if I'm not mistaken. We're doing all bow ties on Friday, which means the following week, what I'm going to do is I'm going to do one just on case studies. We're keeping the price low. We're keeping the price low. The course is not $449.99. It's $319.99. $319.99. So again, we're keeping the prices low. Look, I went to and I called them the suits. Okay, I went to the suits. The suits are the law team, the financial team, the IT team. They're the ones that don't dress and act like me. So I went to them and I said, look, dude, times are tough. Okay, like we're struggling to get groceries over here, and we cannot be charging our students this much. So please take advantage of these cheaper prices, because I fought tooth and nail to get these prices for our students. So just take advantage of it. Take advantage of it. What else do we got here? Okay, here's the course. Again, it's from September 30th to October 18th. Majority of the course is taught by myself and Nurse Brittany. Majority of the course is taught by myself and Nurse Brittany. We do have a few other instructors that pop in for a couple other sections. There, if you can't make it, there's stuff on demand for the ones that you miss. You can get notes from your fellow peers as well too. But again, it is $319.99. $319.99 is the cheapest I've ever seen this course. Period. So if you're even thinking twice about it, that's $100 a week. That's like $12 a day. You know, skip a coffee, skip a sandwich, make it at home, and get your pass, because I promise you it'll be worth it. It'll be worth it. So there will be a scholarship opportunity coming up here. We'll announce that on an email on Friday. Scholarship will be announced on Friday. So scholarship email is on Friday. So it'll go out in an email on Friday. You can apply for the scholarship, and then we will they will choose one here in the next over the weekend. They'll choose one over the weekend. The on-demand, like I said, it was 200 something. I didn't know how much. The on-demand is $239.99. $239.99. Again, it's all the way down from $449.99. Everything is dropping in prices. Take advantage of it, especially if we're getting to the end of the year. All these little holiday things that are happening, all these little winter break and everything, take advantage of it. Take advantage of it, because the test is consistently changing. I'm telling my students right now, look, take it now. Take it as soon as possible, right? Here's some examples. Look, September 13th, September 15th. Look, I couldn't make this up. 85 and out after 5 years. 85 and out. Whoops, we shouldn't be putting people's names on there. Sorry about that. But yeah, look, we've got what's it called? 105. It doesn't make a difference. A pass is a pass is a pass. This is somebody that didn't even have English as a first language, right? So again, look, we're doing something right when it comes to this course and all the stuff that you're getting, which includes today's lecture. So while we get into section again, remember today we do have trivia right after. Today we do have trivia right after. Top 5 people do get they do get prizes. So I know we saw some people email us for the prizes from last week. If you won before, please just let us know so that way we can go down the list and let somebody else benefit from the prizes as well too. So with that said, sorry, let me make some notes. There will be a discount for those of you that do enroll in the live course. The entire box that we have that includes a planner, abbreviation, a quick tip book, cardio book, a doodle book, a t-shirt, a cup, a badge, a pen, so stickers, so on and so forth. There will be a discount that will be emailed out to those that enroll in the live course. So you'll look out for that email. It has our material in it, so that way you have it ready for when we start the exam or start the course as well too. And this is not the updated version of this. No, it is. Okay, cool. All right. So ask graph. Now look, there are a lot of different ways to approach prioritization. But prioritization now I want everyone to pay attention here real carefully before we look at the notes and everything or start taking notes. I want you to pay attention to why prioritization is so important. Prioritization is going to put you in a situation where you've got to choose amongst 4 patients. You've got to tell me which one you are freaking out about, but not only that. The reason why students love Ask Graph is because it makes you look beyond just an ABC perspective. It's not just airway, breathing, circulation, which I'm not knocking, but it didn't work for me. Airway, I get, but breathing and circulation, it wasn't specific enough for me. It didn't make me find what I'm looking for. And I would overlook things because I was looking for airway, breathing, circulation. I needed more specificity. But let's take it a step further. Every single person in here, for the most part, is going to have to interview, especially if you go into the hospital. Fair? If you have to interview, do you know what they're doing right now in interviews? And this is coming from all my students. They're giving you a case study and they're giving you prioritization questions. That's how they're interviewing now. Can you figure out in a scenario where you've got an H&P or a physical exam or lab values or imaging, and you've got to diagnose and you've got to answer what's going on, and they're giving you prioritization questions. This is part of your interview process. So this is not just for the boards. This is also moving forward beyond the boards. This is for your interviews. Which, by the way, if you're in the live course, I tell my students 3 things. Keep your invoice because you can ask for a reimbursement once you get offered the job. 2, we give you a letter of recommendation as well once you pass with us. And 3, I will personally be your reference because they send out ones where it's like a scale of 1 to 7 or 1 to 10. You pass with us, I give you all 7s or all 10s, whatever it is. I've got your back. Okay, I've got your back on that. So now we get back to prioritization. And like I said, ABCs didn't work for me. Pyramids didn't work for me. But Ask Graph was something that I had to learn. I had to figure out, hey, there's more than one thing that could be happening. And I need to prioritize. I need to figure out which one I'm freaking out about. So I use this term FOA, freaking out about. Because ultimately, I've got to ask myself not only to find one of Ask Graph in there, not only to find one of Ask Graph in there, but then I've got to ask myself, these following questions. Now, I want you to write this down. This you must write down. You've got Ask Graph. Ask Graph is everywhere. It's on YouTube. It's on the podcast. It's on all our social media. You're here now learning about Ask Graph. But this is where I'm taking it a step further that I don't talk about elsewhere. But those of you that are here today are going to learn this. I want you to ask yourself two things. Who do I have less time with? Who do I have less time with? And what more can I do? That's part one. Who do I have less time with? And what more can I do? Now is something brand new. I just thought of this while I was doing group studies. So those of you that are my students that have heard or seen me do things live and come up with things, this was one of those things that I saw. I was like, wow, this is something that I need to know. This is part two of Ask Graph now. I want you to know the difference between what is happening versus what could happen. The first one is, and I'm going to modify Ask Graph here. That's why I forgot to add it into this slide. I did modify Ask Graph. Thank you for bringing that up. So a lot of new stuff added to Ask Graph and prioritization. So I'm glad that you all are here with me today. Less time with, well, yeah, because I'm freaking out about that person. And then what more can I do? And we'll kind of get to that. Like example, like a patient is septic and is receiving antibiotics. Well, what more can I do? Give them fluids, give them antibiotics. Yeah, okay, cool. So now I got to look at somebody that needs something done or has less time with me. So that's part one. Part two is what is happening versus what could happen. Well, a patient has a potassium level of 3.0. Well, they could develop dysrhythmia. Have they gotten there yet? No. Right? So again, and we'll see these, and it's up to you to decipher which one using the criteria, starting with Ask Graph and moving forward. There are some modifications that I've made on Ask Graph. The first one is in H, we are now adding heart attack. We are now adding heart attack. I did update this on Instagram. So if you're following us on Instagram, it is updated on there. I was going to add stroke here, but I decided not to add it as another S because in reality, a stroke, whether it be ischemic or hemorrhagic, is going to present with altered mental status or is in fact a hemorrhagic stroke, which could be altered mental status and hemorrhaging. So again, very important that we are taking advantage of these mnemonics that I've come up with, because Ask Graph is nowhere to be found. This is something that I came up with and something that's going to help you. So what is Ask Graph? It is what we're freaking out about. Airway, above all else. You see airway, you are freaking out about it. There is nothing more important because we don't have time. Our brain needs oxygen. We don't have time. Sepsis, there's a triad. What's the triad? Hypotension, tachycardia, and they could be below 96.8 degrees or above 104, hypothermic or febrile. Hypothermic and febrile. Changes in potassium. Things like diuretics is a big one. Huge topic on the boards. Diuretics, potassium wasting. Well, in this situation, We've got hypokalemia or hyperkalemia. It doesn't make a difference. It's changes in potassium that are causing this. So any change in potassium, low or high, is going to cause a dysrhythmia. Those that were in the EKG course with me or EKG class with me, how well do we understand how the heart works now? And now potassium is changing the ventricle, and we're worried about the most deadliest dysrhythmia. 100%. There you go. Glucose less than 70, our body's going to shut down. We're going to become comatose. Our metabolic pathways need glucose in order for it to function. So very important that we are looking at the signs and symptoms of hypoglycemia. But in order to know that it's the one that we're freaking out about, they're going to say comatose, which will kind of indicate that they're altered mental status as well too. But they're also going to indicate to us that the glucose is less than 70. What if it's 70? No big deal. Normal is normal for the boards. With pediatric patients, we're talking about lethargy or grunting. Lethargy or grunting. Because in pediatric patients, it's hard to get any information out of them. So the boards must describe that they are severely in danger, that we are freaking out about them, that we don't have time with them, that something is happening. So we use the words lethargic or grunting. Altered mental status. So things like hallucinations, delusions, seizures. All of a sudden, acutely, in the last hour, disoriented, indication that this patient has altered mental status. We're freaking out about it. Peritonitis, again, the peritoneum encases GI and reproductive tract. So we're worried about words like rebound tenderness, guarding, rigidity, board-like abdomen. And then the last one is hemorrhaging and heart attack. Well, if a patient has decreased blood pressure, increased heart rate, we're looking at hemorrhaging, heart attack, elevated troponins, ST segment elevation, chest pain with diaphoresis, radiating to the jaw, radiating down the left arm. All these descriptors that, in fact, should be like this when you're looking at it on test day. You should be like, whoa, this is this is that, this is this. This is part of Ask Graph and which one it is, because those that are in the course, you all see all the descriptors that I've given you in your notes. Those are associations you should make right away. So on test day, which is why we started doing trivia. The reason why we started doing trivia is because I want those neurons firing, make those associations. They're not board-like questions when I do trivia, but they are making you think fast. They're forcing you in 20 seconds to make an association, read fast, and make a decision while having fun. So there's a method to my madness, clearly. So this is Ask Graph. And of course, we go way more in depth with it, but this is a little scratch the surface, but some additions that we have made regarding Ask Graph. So now, the boards are constantly changing. I try to tell students this all the time. When we first started the next gen questions, they used to be 10 to 15%. Those are my students that are getting 85 and out. More than half of their exam is next gen. More than half, 5 to 6 case studies, 3 to 4 bow ties. Do the math. That's like 40, 45 questions out of 85 that are now next gen. The boards are changing. We're adapting with them. So as things change, make sure you're trying to get it done as soon as possible. I know everyone wants to get it done as soon as possible, but I'm giving you another reason too. The method is key because you may get stuck on a question. And I made these ones particularly hard with the help of Nurse Brittany. You put two of our brains together and we're really going to mess with you. So I apologize in advance, but it's done for a reason. It's done for a reason. I want you to see exactly what's going on. All of these are prioritization questions. So what do prioritization questions end with? First, initial, priority, urgent, most concerning, immediate, report to HCP. These 7 words, first, initial, priority, urgent, most concerning, immediate, report to HCP. These are the 7 words I'm going to ask you amongst 4 patients to see which one you're freaking out about. And please do not jump ahead so we can all learn at the same time. I appreciate that you know it. But again, please don't jump ahead. So we start with number 4 and we just compare it to number 3. That's all we're doing here. That's it. Don't even go beyond that. I know I'm looking for what I'm freaking out about. And I know that I'm looking for Ask Graph here. So let's find it. So we got a 55-year-old female with stable angina, complaining of chest pain 6 out of 10 after walking to the bathroom, now resting in bed. Or 75-year-old male with a history of AFib who suddenly developed slurred speech, right-sided weakness, and an irregular heart rate of 130. So yeah, in this situation, we are going to go C over D because, again, look at the keywords here. Stable angina, which means what? That I can tell you to go walk a block or to go up 2 flights of stairs and I can elicit that pain, right? 6 out of 10, I'm not really freaking out about that. And now resting in bed. I'm not really concerned about that. Concerned to somebody that suddenly has slurred speech. Well, which one of Ask Graph is this going to be? If they're starting to develop a stroke, it is altered mental status. Thank you. It is, because we're having some sort of a stroke. Which type of a stroke? Now, look at how much content I'm telling you right now. Look at the way I'm breaking down questions. We just went to stable angina. I gave you the signs and symptoms. Okay, cool. I can elicit the pain. Okay, they're going to have a 6 out of 10 pain. We can talk about coronary artery disease. I can go back to unstable angina. I can talk about statins and nitrates. And whoa, Dr. Z only went through D. And now we go into, and that's just cardio. Now we go into C, and now we're like history of AFib. Okay, I know that what that strip looks like, the P wave, irregularly irregular, or no P wave, irregularly irregular. Okay, cool. I know how to do that. I know how to treat it. But now they got a sudden slurred speech. So I went from EKGs, not a neuro. Right-sided weakness, irregular heart rate. Ooh, they could have thrown a clot. Whoa, if they're having a stroke or a version of altered mental status with the slurred speech, right-sided weakness, because they're having a stroke, now I know it's ischemic. Now I'm like, wait a minute, is this thrombotic or embolic? Now I'm all the way in neuro. So which one is this? Is this thrombotic or embolic? If they have a history of AFib, more than likely it's embolic. But nonetheless, we are sticking with C over D. But do you see how much information I just spit up off the top of my head? My students know this. They make those ties. Now we compare C to B. We're just using the method. 42-year-old female with end-stage renal disease who missed dialysis yesterday, nausea, fatigue, potassium 6.5. Whoa, wait a minute. Which one of Ask Graph is this? It's potassium. So which one am I choosing? Am I choosing the potassium or am I choosing the altered mental status? And why? So I'm getting mixed answers here. B over C and C over B. I'm getting more towards C over B. Good. Those, and I noticed the names of my students in the courses. C over B and why? What's a couple of things that I'm looking at here? If they have end-stage renal disease and they don't have dialysis, it's expected that their potassium levels are going to go through the roof. Could they? Now, remember, this person is having a stroke. This person could develop VFib. Do you see how I just took the stuff I just taught you and applied it? I've got 2 of Ask Graph. For sure, I'm freaking out about both of them. I've got altered mental status, I got potassium. One is kind of expected because of the potassium levels, because of end-stage renal disease, and no dialysis. But one could develop. Do they have any type of palpitations? Any type of chest pain? Any type of lightheadedness? No. Do we see anything on telemetry? Well, they're not even on it. So you see what is happening versus what could happen. So those of you that chose B over C, I understand why you chose that. Those of you that understand C over B, this is how I want you to think. This is how I want you to think. So good. This is why the method helps you. Now, wait a minute. The reason why we use the method, am I going to go back and change my answer to B? Absolutely not. I chose C over B. I use the method. I'm not going backwards because I am so guilty of doing that. Consistently changing my answers back. And I was like, now I need to develop the method. Now we're down to 50-50 in a prioritization question. So now we've got a 68-year-old male with chronic heart failure who has bilateral 3+ pitting edema on continuous IV infusion of furosemide, reporting a mild headache and shortness of breath. Whoa. We've got airway here, don't we? But why C over A? Again, expected. They're not giving us O2 sats of 88% or below. They're not telling us that this person is agitated or anxious. You see how I would take it a step further if I really had less time with this patient? So again, look at the situation here. Yeah, we're getting furosemide. Do you think I should start knowing what furosemide is while I'm doing this practice question? Oh, dang. Oh, it's a drug. It's a loop diuretic. I use it for heart failure. Wait, what type of heart failure? Is it chronic heart failure? Okay, shortness of breath, pitting edema. Okay, so it's definitely complete heart failure because I've got peripheral edema. I've got shortness of breath in my lungs. I've got all the signs and symptoms. You see how much information in one question I'm already thinking about because I've learned all the content. This is how I want you to learn. A lot, right? How do we feel about the first question? This is how we're going to be getting down today. So cool. Awesome. All right. Again, it's a prioritization question, so I'm not going to read them all out to you. But again, same thing. First, initial priority, urgent, most concerning, immediate. Report to HCP. So let's start with the method so we can try to get through as many questions as we can. So the first thing is we're going to look at D and we're going to compare it to C. So we've got a 66-year-old post-op thyroidectomy patient who is reporting tingling around the mouth and hands and has a calcium level of 7.2. Or a 72-year-old post-op hip replacement who is alert and oriented, but is reporting new onset shortness of breath and chest pain. Which one are we going with? Yeah, why are we going with C over D? Well, with calcium, we're going to have to correct the calcium level. And why did we get hypocalcemia post-op thyroidectomy? Now I go right into endocrine. Because I probably took out my parathyroids, right? So am I okay with that? No. Then I think about chopstick and I talk about trousseaus and my mind starts to go, wow, okay, cool. I know my content. I'm feeling confident about taking my exam. And I compare that to my 72-year-old post-op hip replacement. Well, they're alert and oriented, but they've got new onset shortness of breath and chest pain, but they are alert and oriented. Okay, cool. I'm still choosing C over D. Now I compare B to C. Yeah, this does become potential airway, right? Shortness of breath, chest pain. By way of what? What have we developed here? pulmonary embolism. What type of pulmonary embolism do we have here? Somebody give me the mnemonic, fat, bat. Which one of them is it? I'll take two. I'll take fat because it's a hip, or thrombotic, right? So yeah, thrombus or fat. I will take either one of them. Maybe they're immobile post-op, and or they developed a fat embolism. So yeah, either one of them. Now we went to respiratory. I've talked about almost every subject so far. We're only in 2 questions, not even a question and a half. So now we compare C to B. A 49-year-old post-op laparotomy patient with nasogastric tube in place, now reporting a sudden increase in abdominal pain with a heart rate of 110. Whoa. Now we've got potential peritonitis. But of the two, which one are we freaking out about? C over B, right? I would agree. I would agree. I would opt to go with C over B because, again, that shortness of breath, I'm concerned about that pulmonary embolism, whereas peritonitis, I may need a little bit of imaging. I may, again, do what? NPO, IV fluids, pain as needed, NIPA. Look at, now we just brought in NIPA, right? So again, of the two, who do I have less time with? I would say C as well too. Good. Excellent job. Excellent job. Way to apply everything. Now we're down to 50-50. Like I said, on test day, if we're down to 50-50, we're sitting pretty. Now we're down to a 58-year-old post-op coronary artery bypass graft, or CABG, patient whose chest tube output is increased to 150 in the last hour with a blood pressure drop of 90/60. Whoa. Now I've got hemorrhaging. This is a tricky one, and I'm going to get into ASH right when we get done with this. Okay, let's think about this. In C, we do have shortness of breath and chest pain. They do have an embolism, more than likely, but they're alert and oriented. What am I going to do in a situation where they have an embolism? How do we treat a PE? Somebody tell me, what's the first thing I'm going to give them? Or I'll take them simultaneously. First thing I'm going to give them is what? Oxygen. Give them oxygen. In this one, they're hemorrhaging because their chest tube drainage has increased over 100 milliliters per hour. All of a sudden, in the last hour, it jumped up. We should be well below 100 milliliters per hour in chest tube drainage post-op with the CABG. They're hemorrhaging, but more specifically, where are they hemorrhaging? What if I told you that they had a muffled heart sound? Good. What do they have now? I didn't tell you they have a muffled heart sound. I told you they're hypotensive with the chest tube post-CABG. Do you think I want you to know that they're tachycardic at this point? Yes. Do you, or not tachycardic, sorry, I take it back. That they're hypotensive? Yes. Do you think that they probably have a JVD? Yes. Do you think that they have a muffled heart sound? Yes, because that is, in fact, Beck's triad. And that indicates that we are having a cardiac tamponade. In a situation where a person has pulmonary embolism, whether it be a thrombus or it be a fat embolism, we're giving them oxygen. Then we're probably getting them on heparin. Even though this is airway, they're still alert and oriented. Now, if they weren't alert and oriented, now what do we do? Whoa. Now we have a different decision to make. But I've given you that they're alert and oriented. You see how every part, do you see how majority of people are going to focus and fixate on the shortness of breath? But they're not realizing that the person is alert and oriented. Now I look at a 58-year-old, they just, boom, their chest tube is full of blood and they're hypotensive. It's your job to logically deduce, even if you didn't know that this was a cardiac tamponade happening, you must deduce that if this person post-CABG is losing copious amounts of blood, they are actively hemorrhaging in a chest tube in a major surgery where we went in and we, now think about this. Not only did we do a CABG, we sewed them back. We didn't sew them back shut. We wired them back shut. So now we're gonna have to go in and do what? If I got to remove that fluid, we've got to do what? A pericardiocentesis under 100 milliliters per hour. 100. So the question was, what is the normal chest tube drainage? Under 100 milliliters per hour. So that way you can see, and significantly less than that. Okay, 100 is pushing it. 150, we're well above hemorrhaging now, or we're well into hemorrhaging right now. So again, think about it. Yeah, I do have, look, I got peritonitis, but again, NIPA, NPO, get that NG tube out. Maybe we don't need to be doing that. Maybe we get them on, make sure they have IV fluids, which they probably do already. Pain medications as needed. Get them ready for some imaging, antiemetics. You see, we've got time. Even with this one being airway, it's not necessarily airway. It is shortness of breath and chest pain, but am I agitated? Am I anxious? Are my O2 sats tanking? Am I disoriented? No, I'm not. I'm alert and oriented. In this situation, this person is actively hemorrhaging from a CABG. I told you I was going to make them tough. But the reason why I made them so tough is because I wanted to do it for multiple reasons. One is I really want to get the brains going. Now, look, people tell me this all the time. There's actually there's so many people out there that come to me and say, Dr. Z, will you be an affiliate with us? Will you work with us? And will you promote us? Right? And in certain instances, I'm like, cool, yeah, I believe in the product. In certain instances, I'm like, no, I don't. Okay, it's my ethics. I'm a very ethical person. So yeah, no, absolutely not. People come to me all the time. They're like, Dr. Z, well, your questions are specific, and some of them, like on trivia, are vague. Who cares? Does that make a difference on boards? Vague versus specific? Somebody tell me, and why? No, it doesn't. Because at the end of the day, if I know my stuff, if I know my content, if I know my test taking strategies, ask me vague or specifically, I don't care. I'm going to get it right. I'm going to get it right. So very important. So yeah, in this situation, we are 100% going with C. Or sorry, we're not going with C. We're getting rid of C and we're going with A. We're getting rid of C and we're going with A. So you see why, though. It's not about just getting the question right. It's about understanding why. So again, we're worried about that cardiac tamponade. But even if you didn't get there, I want you to take those two things that I taught you in the beginning. Who do we have less time with? What more can we do? And then what is happening versus what could happen. Airway could have happened. Shortness of breath was there. Chest pain was there. It could have happened. But then the cardiac tamponade is happening. The hemorrhage is happening. All right, same thing. Who are we going to see initially? Again, one of those key words. So now we start with D and we compare it to C. A 70-year-old male with a sudden severe headache, nausea, and vomiting reporting a thunderclap, notice the quotes, onset with a blood pressure of 180/10 versus a 60-year-old female with a history of COPD reporting increased shortness of breath, O2 sats of 89% on room air. Again, we use that word expected. They're on room air. They're not even on O2 with COPD. They're at 89%. We're not under 88%. There's no agitation, disorientation. But that thunderclap, which one to ask graph am I thinking right here? Severe headache, nausea, vomiting. what are we thinking is happening in D? Altered mental status by way of stroke. By way of stroke. What type, excuse me, what type of a stroke do you think we're having here? In this situation, that thunderclap, or the worst headache of my life is hemorrhagic. Yeah, it's more than likely, somebody said it, it more than likely is a subarachnoid hemorrhage, that worst headache of my life, that thunderclap headache. So it is a hemorrhagic stroke. So I would take altered mental status or hemorrhaging. And then again, treatment. What do we do in a hemorrhagic stroke? With when we went to thrombotic or ischemic, thrombotic versus embolic, we've got what? We've got TPA. We got to know all about TPA. But then we got a subarachnoid hemorrhage. What are we going to do? In both situations, what do we start with? We start with what? We start with the CT, right? And then now we got to do what? One is surgery, one is going to be potential medication. You see, now I just went into neuro even more. So again, very important that we understand our content. B, a 45-year-old male with a recent history of deep vein thrombosis, a DVT on anticoagulation therapy, now reporting a severe flank pain and hematuria. So what is going on here? They've got hemorrhaging, they're bleeding, severe flank pain, and blood in the urine, hematuria, on anticoagulation therapy. Well, what are we going to do in this situation? Between this person and this person, which one am I choosing and why? So I'm seeing D over B, because what are we going to do here? And again, one of those things that I teach my students all the time, stop the offending agent. Stop what's causing the bleeding and prepare to administer the antidote. Prepare to administer the antidote. Again, common things that I teach you all. They're going to come in so handy on test day. I promise you that. Now, vitamin K or protamine sulfate, we don't know. We don't know what they're on, right? I mean, if they're at home, more than likely, we'd say vitamin K because we're thinking that we discharge them with warfarin. But you see how my brain started going now into pharm, into anticoagulants, right? So again, yeah. Now we're down to 50-50. Again, we're sitting pretty. Now we got a 38-year-old female with a history of diabetes, presenting with fever, tachycardia, blood glucose of 425, suspected DKA, diabetic ketoacidosis. Yes, I would agree with you. I do think that this is D over A, but look, why I wrote this question the way that we wrote it, why we wrote this way, is that what did I throw in here? Those of you that are in the course that have the on-demand, what are these two in that first day of lecture? Good. They are distractors. They are distractors, right? People can come in with 425 glucose. Okay, they probably didn't even know. Even if they have signs and symptoms, we still have time. Give them IV fluids. Then we give them insulin with potassium, right? So with this one, we've got to act fast before we get permanent brain damage, right? Excellent job. Excellent job. All right. So again, prioritization question. Let's go through each one of these. D compared to C. So we got a 72-year-old male with Parkinson's disease who has been off his medications for 24 hours, reported increased tremors and muscle rigidity. Compared to C, a 60-year-old female with a history of epilepsy who is now drowsy after having 2 seizures in the past hour with a respiratory rate of 10 breaths per minute. Even if I don't know what's going on in this situation, what do I have in C and what do I know about D? Airway in C and D if they're off their medications, is good. Use that word. It's expected. Excellent job. We can now compare C to B, a 55-year-old male with Guillain-Barré syndrome who is experiencing increased weakness in his legs and hips over the past hour. Wait a minute. So with Guillain-Barré, at what point in time am I freaking out about Guillain-Barré? Guillain-Barré is an ascending paralysis. Ascending paralysis, meaning it starts from the feet and it works its way up. And now it's at the hip level. At what point am I concerned that it becomes airway even more so than this situation? In this situation, we're worried when it hits the thoracic level, I'll take that. When it hits the diaphragm, I will take that, because then my respiratory system is about to fail. In this one, it's kind of still working. In this situation, if it got to my diaphragm, it's about to fail. We may have to do it in both situations, but that's why it's very clear that this is not airway, because in this situation, we may have to do mechanical ventilation. We may have to intubate this patient if we cannot get their respiratory rate up. Now we're down to 50-50. A 40-year-old female with myasthenia gravis reporting new onset, double vision, and difficulty swallowing. So what are we worried about with A? That dysphagia is definitely important there. But in fact, we are not worried about this because this is expected. What can we give them? Now let's do some farm in musculoskeletal. What medication do I give them to help them in this situation? Pyridostigmine. Pyridostigmine. So look, I just took it to farm in musculoskeletal on myasthenia gravis, because pyridostigmine will get rid of the difficulty swallowing and the double vision. So yeah, this is expected, but again, we take it a step further. So now, again, we've got 10 breaths per minute. That respiratory depression is very important as well, too. All right, let's make this our last one, and then we'll start getting ready for trivia. Last one, and then we'll get ready for trivia. So we've got patient step-down unit, again, who we're going to see as a priority. There's that key word that I'm looking for. And now I've got a 33-year-old female with lupus who is reporting increased joint pain and a new rash on her face, or a 56-year-old male with cirrhosis and slight confusion with ammonia levels that are elevated at 115. So what are we thinking here? I'm going to agree with you, because lupus, we know the signs and symptoms, as we should for the sake of the boards, because as we will learn, those of you that are in the course, tomorrow we've got musculoskeletal, we'll talk about this great case study type of a question. And then now we've got the ammonia levels that are elevated in cirrhosis. We talk about the ABCs of cirrhosis, right? So yeah, ammonia levels, altered mental status because of hepatic encephalopathy. So I would agree with you. Now we compare that to a 45-year-old that is post-op 3 days from hysterectomy with a heart rate of 125 and a blood pressure of 88/60. Which one are we freaking out about between the two? B over C, because this one is hemorrhaging and we need to do something quickly. Post-op day 3, they should not be bleeding. They should not be hemorrhaging. And is this 100% indicative of hemorrhaging? Or could this be something else? What else could this be? It could be sepsis as well, too. Yeah, 100% this could be sepsis as well. So now this one is slight confusion. I have time. Go back to that whole thing. So now we've got somebody post-op day 3. They could be septic, I'll take it. They could be hemorrhaging, I'll take it. Either ways, I've got something that is happening. Ask graph. As a matter of fact, we take it a step further. This is in fact ASH because it's post-op. So in post-op, we narrow ask graph down to airway, altered mental status, sepsis, and hemorrhaging because you don't want your patients to turn to ashes post-op, post-procedure. So now we're down to 50-50. A 68-year-old male with heart failure reporting 4+ pitting edema in the lower extremities and shortness of breath at rest. This is airway. Well, what are we going to do? We're still going to stick with B over A. We're still going to stick with B over A because, again, what are we going to do in this situation? Probably get them on diuretic. Before we even get them on a diuretic, what are we going to do? What can we do that's least invasive to make them feel a little bit more comfortable? I would take oxygen even before that. How about position? Yeah, position them. Elevate the head of the bed. You see, now I'm talking about the treatment of heart failure as well too. So yeah, look at how much we covered in such a short period of time. So with that said, I hope everyone enjoyed this lecture.